Dive. Today, we're pulling back the curtain on a role. It sounds maybe a bit admin heavy, but it's actually, well, a kind of mandatory translator.
And a financial anchor, really, for the whole NHS. We're talking about the UK Orthopedic Clinical Coder.
Right. And our mission today, digging into the source material, is to understand how this really technical job keeps major NHS trusts afloat financially, especially in tricky areas like orthopedics.
Exactly, because it's one of the highest stakes data roles you'll find in the public sector. Complex, high-cost treatments.
I think what might surprise people is just how directly linked this role is to the money coming in. Get the coding wrong and the funding, it just doesn't arrive.
It's all tied into that payment by results mechanism, PBR.
PBR, yeah, and the healthcare resource groups, the HRGs.
Yeah.
So this coder, they're basically setting the financial weight for every single patient episode.
Absolutely. The pressure's enormous. Because the job, at its heart, it's like clinical detective work.
Detective work.
Yeah.
How so?
Well, they have to take all the clinical notes, often messy. Admission notes, surgery reports, discharge summaries, and abstract, analyze, translate it all into standard codes.
And deal with all the data rules, too, I imagine. GDPR, data protection.
Oh, definitely. Massive amounts of patient data, so compliance is just baseline. Non-negotiable just to do the job.
So why orthopedics, then? Why is that considered the sort of the deep end for these coders?
It's the sheer volume, really, and the cost of the procedures. Think about joint replacements, spinal fusions, complex trauma repairs.
High cost, high volume stuff.
Exactly. So the coder needs pretty detailed anatomical, physiological knowledge just to even figure out what the notes mean. Sometimes the documentation isn't perfectly clear.
And they have to turn that ambiguity into one single correct code.
Precisely. Using their toolkit, which involves two main classification systems here in the UK.
Okay, what are they?
So for diagnoses, the conditions, they use the international standard ICD-10, the 5th edition currently.
So like M16.31 might be what, arthritis in the right hip?
Unilateral osteoarthritis of the right hip. Yeah, something specific like that.
Yeah.
But then for the actual procedure, the operation itself, they use OPCS-4. That's unique to the UK.
Okay, OPCS-4 for procedures. But let's talk stakes again. Can the difference between two OPCS-4 codes, can it really impact the trust's finances that much?
Oh, massively. Severe is the word used in the source material.
Severe how? Give us an example.
Okay, a common one might be mixing up a primary hip replacement code W37.1, say with a much more complex and therefore more expensive revision hip replacement, maybe W39.3.
Ah, okay. So primary versus revision.
Right. That small difference in code reflects a big difference in complexity and resource use. Get it wrong, code the revision as a primary, and the trust gets way less funding for that patient through the HRG allocation.
So they lose money they should have received.
Yes, and potentially face penalties for submitting inaccurate data. It undermines the whole PBR system.
Wow. Okay. So with that level of skill needed, how do people actually progress in this career in the NHS? It's all under that Agenda for Change framework, the AFC.
It is, yeah. It's quite structured. You typically start as a trainee, maybe band 3 or 4, then move up to clinical coder at band 5.
But there's a key thing that accelerates that, isn't there?
Definitely. The big one is the National Clinical Coding Qualification, the NCCQ.
NCCQ. And getting that makes you an accredited clinical coder, ACC.
That's right. And achieving ACC status is, well, the source material calls it the singular most valuable determinant of getting promoted. Often leads to an almost instant promotion.
And the pay reflects that jump.
Absolutely. A band 4 trainee might be on, around £25,000, give or take? But get that ACC status, and suddenly you're looking at progressing up to senior coder roles at band 6.
Band 6. That tops at over £46,500, right? That's a significant increase.
It really is. That qualification is the gateway. But here's where it gets interesting, the NHS versus the private sector.
The trade-off.
Exactly.
Yeah.
In the NHS, even a very senior coder might top out around band 7, maybe £52,000, £53,000 at the very peak. But you look at agency or private contractor roles.
They're offering more cash.
Often, yeah. You see experienced ACC contractors advertise for rates that could equate to £60,000 a year, sometimes more.
Okay, so that's quite a bit more in your pocket each month. Seems like a no-brainer, maybe.
Well, that's where you have to look at the total package. The source material really flags this. It's the NHS pension scheme.
Ah, the pension. Always the hidden benefit.
And it's not so hidden here. The employer contribution rate in the NHS is huge. It's 14.38% of your salary.
14.38%. Wow. How does that compare to the private sector average?
The average private sector employer contribution is quoted around 3.2%.
3.2 versus over 14. That's an enormous difference in long-term benefit.
Colossal. So essentially, those private agencies have to offer significantly higher cash salaries just to try and compensate for that incredibly valuable government-backed pension benefit you're giving up.
So it's a classic trade-off. Higher immediate cash versus much, much better long-term security.
Precisely. It depends on your priorities, your life stage, your risk tolerance. Are you focused on the now or building that long-term nest egg? That's the constant calculation for these in-demand ACCs.
So wrapping up this orthopedic clinical coder role, it's really this blend of deep medical understanding and sharp data science. Getting that OPCS-4 code right, distinguishing a W37.1 from a W39.3, isn't just admin, it's directly generating income for the hospital.
Absolutely critical function.
So here's a final thought for you to mull over. Based on everything we've discussed, you see those high cash offers for contract coders. What does that constant demand tell us about the NHS's immediate staffing pressures?